So good afternoon, everyone. Let's get started with the next session. We have a total of 10. We have a collective of 15 minutes for the discussion. So may I request Dr. Senguta and Dr. Maurya to kindly take the lead in this session. Do we have Dr. Senguta?
Yeah.
Yes, Dr.
So a very good afternoon to all. Yeah. So a very good afternoon to all our respected seniors and my colleagues. So I and Dr. R.P. Maurya, we welcome you to this update session, tips and tricks of best research publication, learn it from the masters. Now this update session has followers from the field of ophthalmology who will share tips which will help you to immortalize your work through publication. Now, without further ado, I move on to the first presentation. It is my pleasure and honor to introduce Dr. Chandrima Paul, who is an internationally renowned expert in the field of glaucoma. She is a fellow of the Royal College of Surgeons of Glasgow and completed her PhD in ophthalmology with the subspecialty of glaucoma. She is presently the director and consultant of BBI Foundation Hospital, West Bengal, and she is the honorary general secretary of the GSI as well as the honorary president of the Kolkata Academy of Ophthalmology. It is my pleasure to invite Dr. Chandrima Paul to give her talk.
Thank you very much, Dr. Subhrangshu, for those kind words. And can I right away share my screen?
Sure, ma'am.
Okay, so thank you, Dr. Subhrangshu, once again for having me in your course. And in the next few minutes, I'm going to take you through writing a review article and meta-analysis. So I'd like to start on a very positive note. Those of you who haven't written yet, start writing. Those of you who are writing, start reviewing and doing meta-analyses, because your point of view creates your reality. That's the only place where your reality remains even after you in the sands of time. So hierarchy of research designs and levels of scientific evidence. So if you have a look at this, clinical practice guidelines and meta-analysis and systemic reviews actually secondary, reappraised or filtered studies. So these are when you actually do filtered studies, and the rest of these are all primary studies. And so today we are going to concentrate in my talk on meta-analysis and systemic reviews. So as the diagram is self-explanatory, you review literature, you actually combine it and pick up the points and make a systemic review. And meta-analysis actually is a part of systemic review itself. So literature review is a survey of previously published research on a topic, involves reading the selected text in detail and other related texts to present a fair and reasonable evaluation. So difference between a research article and a review article. Viewpoints are different. This is actually, you bring out in a review article the positive criticism of the other authors. The content is assessing already published content, which is not new content like a research article. And the length depends on the word limit provided by the journal where you want to submit for a research article. But in a review article, it tends to be much shorter. And sometimes it's an invited article, so you would be given the word limit. So review article objective is to provide a critical evaluation of the data available from existing studies and can identify new potential research areas and sometimes draw new conclusions. Other considerations would be to provide a comprehensive foundation on the topic, explain current state of knowledge, highlight the main methodologies and research technologies. So if you look at that PRISMA statement, a 27-item checklist for review articles, we start with the title, identify the article, move on to the structured summary, write a structured summary, including as applicable background, objectives, data sources, study eligibility, etc. Then on the introduction, you have two parts. You have the rationale and the objectives. The rationale is to explain the rationale for the review, and the objective is to provide an explicit statement of questions which are being addressed with reference to participants. Then you have the rest, like indicate protocol and registration, indicate if a review protocol exists, eligibility criteria, specify study characteristics, sources of information, survey, study selection, data collection process, data items, risks of bias in the individual studies, summary measures, synthesis of outcomes, risk of bias across studies, and additional analyses. So to come to the results, study selection. So given the number of studies screened, assessed by eligibility, study characteristics, as I also mentioned before, you've got to mention the study size and the method of the study, risk of bias within the study, if it is present, result of individual studies, each one of them that you've reviewed, synthesis of results, risk of bias across the studies, and additional analyses. In the discussion is the summary of evidence, summarize the main findings, including the strength of evidence, limitations, discuss limitations of the studies that you reviewed, and conclusion is providing a general interpretation of the results in the context of other evidences and implications of future funding. Well, that is completely individualized, where you take your funding from. So structure of a systemic review, introduction, methods, results, and discussion. And I just went through these. So steps of a systemic review, again, formulation of researchable questions, disclosure of studies, evaluation of its quality, and synthesis. So review article checklist is complete this checklist before you submit your review article. Have you checked the journal's aim and scope? Have you refined the scope of your article? Did you use multiple search engines? Have you written a descriptive title and abstract using keywords? Did you start with an overview of the topic? Have you presented a critical discussion? Have you included future suggestions for your research in your conclusion? And have you asked a friend to do a final spell and grammar check before you submit it? So to summarize, should be a balanced discussion and evaluation of the strengths, weaknesses, and notable features of the text. If you're doing a criticism, it has to be a very positive criticism rather than a negative one. And if you, again, doing a negative criticism, then you have to bring out the positives from that criticism. So we're moving on to meta-analysis, which refers to analysis of analyses. And the history is was by Carl Pearson. And the first meta-analysis assessed the effect of the therapeutic intervention was published in 1955. So meta-analysis is actually, it is a part basically of the systemic analysis and is a statistical procedure for the synthesis of the results. Several independent studies must be combinable. And meta-analysis is an observational study of the evidence, and you have to have your study 1, study 2, study 3, study 4 should be of the same category. You cannot compare apples and oranges. You've got to compare apples of the same type. So meta-analysis is actually systemic reviews, which gives you the statistical strength of the whole thing, leaving out the bias. You have to actually filter systemic reviews to get the meta-analysis. So the Potsdam International Consultation for Meta-Analysis at Systemic Review, the application of scientific strategies that limit bias to the systemic assembly, critical appraisal, and synthesis of all relevant studies on a specific topic, and meta-analysis, a quantitative overview, a systemic review that employs statistical methods to combine and summarize the results of several studies. So if you again compare systemic review and meta-analysis, I told you right in the beginning, actually, meta-analysis takes its base from systemic review, and it actually gives you the statistical summary of the systemic review. So basic steps involved in meta-analysis: specify objectives, specify inclusion and exclusion criteria, literature search, under which comes the quality assessment and the data collection, sensitivity to analysis, to testing for bias, analysis of the outcome, and finally your conclusion and recommendations. So application of meta-analysis is investigation of adverse effects, new indications for existing therapies, selection from among several alternative therapies. And summary of the principles would be: meta-analysis should be carefully planned with a detailed written protocol, prior eligibility criteria for inclusion, and a thorough search for such studies. The graphical display of results from individual studies on a common scale is an important intermediate step, allowing examination of degree of heterogeneity between studies, and different statistical methods exist for combining the data. And a thorough sensitivity analysis is essential to assess the robustness of combined estimates to different assumptions and inclusion criteria. So standard outcome measures, I've actually gone through them, but this just individual results are expressed in a standard form. If the endpoint is continuous, for example, if you're talking about blood pressure, the mean difference between the treatment and the control groups is used. So, and in the endpoint is binary, for example, disease versus no disease. So it can't be dead versus alive that way. And statistical methods for calculation, overall effect. The last step consists in calculating the overall effect of combining the data, and method used for meta-analysis uses a weighted average of the results in which the larger trials have more influence than the smaller ones. So two types of models are used: fixed effect model and random effect model. Fixed effect model assumes that the effect size in meta-analysis differ only because of sampling error, and they all share a common mean, provides a weighted average of the series of studies. And in random effects, it's a random effect model. We assume two components of variation: sampling variation, as in our fixed effect model assumption, and sample and random variation because of the effect size. So the advantages of meta-analysis are results can be generated to a larger population, and the precision and accuracy of estimates can be given. There's a consistency of the results across the studies. Hypothesis testing can be applied on summary estimates. Moderators can be included to explain variations between study, and the presence of publication bias can be investigated. And it has its limitations as well. It has a high chance of being perceptible to publication bias. Publication bias here can be done purposefully or manipulative results by an accident through unconsciously knowing that it is being done, or and be unaware of it. And poor designs are also mixed with good ones, which can actually skew the statistical result. So badly conducted meta-analysis may be biased. Other than selection bias can be avoided if the basic principles are followed. And then the Cochrane Collaboration, this actually international network of individuals, of institutions, were formed in 1993. And this is actually a library where you can check up, and they regularly update you regarding what's actually going on. So steps for systemic review and meta-analysis: define clearly the questions to be formulated, search all reliable studies addressing the question in different sources, select the studies by means of clear inclusion and exclusion criteria, and evaluate the quality of this result. Extract data from each study and display them clearly, evaluate heterogeneity among the studies, calculate the result of each study, estimating diagnostic accuracy, assess the effect of variation in study validity on the estimate of diagnostic accuracy, interpret the result, assessing how much of the review or meta-analysis can be generated according to the patient's characteristics. So basically, again, I come back to my second slide, which I showed you, that systemic reviews in it do have meta-analyses. Certain portions overlap between meta-analysis and systemic reviews, but meta-analysis is largely a part of the systemic reviews, a smaller part of the systemic reviews. So tips to help summarize meta-analysis and systemic review: one should be careful of meta-analysis that do not opt for a clear and systemic procedure to select and identify the studies that need to be included in your analysis. While creating a systemic review, label or title one should concentrate on the question you want to answer. There is not a necessity to restrict your study to only numerical data, which can be meta-analyzed, and define and mention your analysis plan well before you begin. One should be clear in reporting their methods to keep on the right track. One should follow the proper reporting guidelines like standards, as I told you, PRISMA and MESSER. So I'd like to leave you with the thought that research is creating new knowledge. So please do spend some of your time in doing research. Thank you very much for your attention.
Thank you so much, madam. It was wonderful the way so lucidly you dealt with such a difficult subject. Thank you so much. So we move on to the next speaker, which is none other than Professor Rajendra Prakash Maurya. He's a PhD in ophthalmology and a senior faculty and in charge of the ocular oncology, trauma and oculoplasty unit of RIO of the Banaras Hindu University, Varanasi. For the past six years, he's the editor-in-chief of the Indian Journal of Clinical and Experimental Ophthalmology and International Journal of Ocular Oncology and Oculoplasty. He is a revered a reviewer of various journals such as PLOS ONE Injury Prevention, and sir is also the Joint Secretary of Oculoplastic Society of South Asia. It is my privilege to welcome Professor Maurya for his talk.
Good afternoon, chairpersons and all speakers. My topic is nuts and bolts of writing scientific paper. What is research paper? The research word derived from the French word that means to seek out. It is an effort to seek out the information about the study subject. Research paper is a logical, systematic presentation of your findings, particular subject and research. Then what is the purpose? Purpose of writing a research paper is a dissemination of scientific information and knowledge acquired by experiments or observation to benefit the field. And writing a paper is one of the best way to think about the basic but carefully delineated problems. Necessity of the writing a research paper, it is not enough to good scientist, engineer, doctor, whatever you have to make other people understand what you are doing and why it is important, not matter that how competent you are. Your hard work will usually go unrecognized because of other step in and communicate it more skillfully. So why write a paper? Why not present in a conference or symposium? Previously stated that you don't write because you want to say something, but now you write because you want to say something. As you know, the writing of paper is a skill and communication because advantage is having lasting impact, larger unlimited audience, and other advantage over the verbal communication. How to plan a write a paper? Before planning to write a paper, what do I have to say? First question must be in our mind, what do I have to say? Message should be in a single word. Is the paper writing is worth? If yes, then why not start it? Do you find similar paper? If answer is yes, then forget that research work. And where to publish? With the format of the journal, an article, audience, these should be considered. Then before starting a research work, understand your topic first by studying the reviews, collecting references, attending more and more conferences or symposium on your topic. Then ask some question yourself. Then thinking about the topic. What is it? What shall be the outcome of study? Is it a novel or ideal study, or it is repetition of the some previous work? Then, you know, the research paper are usually invited in different format. The research paper may be in the form of a original article, in the form of case report, short or rapid communication, later to editors, review articles, commentaries, these are. So prepare your research paper according to the fixed format. Then decide the audience and journal. Prepare your research paper in an area of demand or promise to make you successful. The journal may be general like nature, science, and journal may be subject wise like ophthalmology, oncology, nephrology, etc. Then the journals may be specialist like cell, neuron, nature genetics, heart. And finally, you decide the impact factor. Search the impact factor of the journal. Always try to publish, write a paper for high impact journals. Where to publish? You know, in clinical science, about 2 million biomedical papers published every year by more than 20,000 journals, and reading about more than 6 new papers per day. So it is very difficult to target which journal. There should be a strategy to choose the perfect journal. That is topic and journal coverage. Go for website of the journal. What is the scope of the journal? Then ask whether it is peer reviewed or not, and then prestige of the journal. Most important, the length of time from submission to the publication. So these are the criteria. Once you decided your topic and format of the research paper, then get started. Prepare an outline of the paper. Start with easier part first, and don't look for accuracy or grammar. Just prepare and start writing. That is initial draft. Prepare the graphs and tables. Then outline of each research paper is different and is given on the site of the journal, website of the journal. So point, for example, the original article, the introduction, method, result, which include the table, text and figures, then discussion, including the flow chart and conclusion. So prepare an outline of your research paper. You can also talk to your friends and juniors, present your observations and explain the finding to them, and solicit the suggestion and criticism. These all will clear your cloud and confusion. Also consider the priorities of readers, reviewers, and editors, what they want. Reader wants a quality article, easy to access, rapid delivery, convenient format, and low or no cost, and recent update information. So prepare your article accordingly. Then what is the priorities of editor? The editor wants a work which is under the scope of journal. The clarity of English language the author used, and is the science is sound. They also look for the targeted to the journal's audience, and whether the writing paper is new or interesting and big enough advance of these field and these journals. So look the priorities of editors also. Then priorities of reviewers. Reviewers mostly look for quality of the research. That is soundness of the research, suitability of method and analysis, soundness of the analysis and statistics, and reporting clarity of the message and language and presentation. Also contribution to the literature, whether a newer thing or same repeated science matter is in your research work. They also comment on the suitability of the journal's scope, and they can reject or accept your article. They recommend to the editor-in-chief. So always consider the priorities of these. Then challenges in the publication. The task of writing a research paper can be challenging, and even with a groundbreaking research, unless it is not in a correct format, at best publication will be either delayed, at worst may get rejected or never published. So goal should be write a well-structured research paper. As you know, the rejection of a manuscript is the most frustrating experience by any researcher. The reason for the rejection of manuscript may be the poor experimental design, means lack of hypothesis, lack of proper aim of the study, poor recruitment, means a small sample size, short follow-up period, and unjustified looking conclusions, and failure to perform the target journal. Methodology is not described properly, inappropriate statistics, and conclusion not proper given. So how to overcome these rejections? Study did not examine an appropriate issue, review the literature thoroughly, clearly mention the research question. If reviewer comments that study is no interest to the journal, carefully read the journal's aim and target the journal. Then originality. If similar study already done, then what you can do? Bigger sample size, take a bigger sample size, better methods, and different population, use different ethnicity and population. Then if the layout is sloppy, then check the instruction to author and conform accordingly, and check the consistency of your table in the text. How to overcome this rejection? Again, if the poor English and properly unreadable, then keep the sentences short, run the spell check, and involve a medical writer or English speaking collegians. Sample size is too small, then perform a power of calculation to determine the required sample size. Study was uncontrolled or inadequately controlled, then clearly explain how the systemic bias was minimized, selection bias, performance bias, or exclusion bias. If the comment is inappropriate study design was used, then use a study design appropriate to research question. Randomize the clinical trial and highly demanding as well as having highest level of evidence nowadays preferred. Then how to write the structured manuscript? First, write the method. Then prepare, reconstruct your figure and tables. Then write the result section and then introduction. After writing the result and introduction section, start the discussion. That is most difficult part. And then abstract, conclusion, and finally decide your title. The title page, that is a type of manuscript, title of manuscript, author and author affiliation, short running title, give 5 keywords on the title page, and then complete contact information of corresponding author. The title is just an advertisement of your article, so it should be a short, simple, and eye-catching. Clearly and accurately address the content of research. Do not use abbreviations and jargons. So abstract part, reader can decide whether or not to read whole article. So interesting paper with bad abstract may be rejected. So focus on the abstract writing, that is an independent document, typically a single paragraph, and word count is limited. Some journal, they want 150 word or 250 word. So word must be finally chiseled and appropriate. Then first mention the objective, hypothesis, then clearly describe the methodology, and finally about the significance of your result and impact of work. Then in introduction, it requires a short review of the literature, maximum 2 to 3 paragraphs. Lengthy introduction always indicate that the author anticipating the discussion part. So clearly state the problem being investigated, background that explain the problem, reason for conducting the research. These should be in your introduction. Summarize the relevant research and state how your work differ from published work, and then identify the question you are answering. These should be incorporated in introduction. Then method, prefer to use passive as always. Explain how you studied the problem, identify the procedure you followed, justify the selection of subject, means inclusion, exclusion criteria, and explain new methodology in detail. What types of data were recorded, and avoid the duplication of in the text. Dr. Sen, actually Dr. Varun Nayak sir is not participating, so I am presenting, taking few more minutes.
Sure, sir. I have updated the hall coordinator.
Okay, thank you.
Please carry on, sir.
Then for the result, that is objectively present your findings and explain what was the found in study. Add table and figures which is useful to assist the reader in better grasping the message. Table and figures should stand their own title, should be self-explanatory, and abbreviations should not be added at the bottom, that is footnote, and exact p-value should be given in the table rather than quoting non-significance. Then comes to the discussion, which should be clear, sharp, and direct. Length does not translate into the quality, rather it creates confusion. So discussion should be concise, summarize the most important remarkable finding, and contrast these findings in light of other previous studies. Accept or reject the proposed hypothesis. Then comes to the conclusion, that is most challenging section of the writing research paper, should be attempted in the last. Language should be simple and plain. Provide a strong and clear bring home message in your conclusion. Concentrate on the hard finding only. Never put your personal thoughts in conclusion. Reference, include all references that have been cited in the text. and list only relevant references in your text as well as in the reference list. Always avoid references that are difficult to find and avoid the listing of self-publication. The reference can be written in different style. Follow the instruction of author on the website of the journal and then write your references accordingly. It would be Harvard, Vancouver style, APA or MLA style. In Harvard style, the references are arranged alphabetically by the author, while in Vancouver reference style, the references are arranged in numerical order as in the text. Then never forget the acknowledgement. Provide a brief statement acknowledging the effort of any participant or consultant who are not included as an author of the manuscript. State all the funding sources for the work, ensuring that the statement adhere to the guidelines provided by the funding institution. The authorship and originality, that is plagiarism and ethical consideration, financial disclosure, will be covered by Honorable Professor Natarajan sir in the next talk. So I'm giving the publishing tips. The editor and reviewers are looking for original and innovative research that will add the field of study. So write accordingly your paper. For a larger study, it may be better to produce one important research paper rather than number of average incremental papers. And don't forget and get frustrated if the manuscript is rejected. Any attempt to reshape and draft and resubmit it to different journal is always better than dropping it into a dustbin. Thank you.
Thank you so much, sir. So now I quickly move on to the next talk. I am Dr. Subhrangshu Senguta, and I'll be speaking on research hypothesis, data collection, and database building.
Excuse me, Dr. Subhrangshu. May I introduce you yourself?
Yes.
Dr. Subhrangshu Senguta is a FRCS Glasgow, and he is a PhD in ophthalmology and working as a senior consultant in Center for Sight, Kolkata, as a expert in medical retina, neuro-ophthalmology, phaco and refractive surgery, and he takes a keen interest in medical research. And now, Dr. Subhrangshu, please.
Thank you for your kind words, sir. So coming to the research hypothesis. A research hypothesis actually translates a research question into a prediction of expected outcomes. The research question itself identifies the variables or concepts under investigation and asks how the concepts might be related, and hypothesis is the predicted answer. So what are the essential elements of defining variable, whereas the outcome is of the dependent variable? A good research question should have finer characteristics. So it should be feasible, interesting, novel, ethical, and relevant. Now, looking at the research hypothesis, what are the characteristics of a good research hypothesis? There should be conceptual clarity, there should be objectivity, specificity, it should be relevant, consistent, it should be feasible and cost effective, and it should have profundity of effect on the research variables. So what could be the sources of hypothesis? Could be theoretical or conceptual frameworks, could be previous research, could be academic literature, and of course, could be real life experiences. What are the types of hypotheses? Simple hypothesis, wherein we are basically looking at two variables. Complex hypothesis, wherein a number of variables are involved. Hypothesis could be associative and causal. It could be directional. Like, for example, we might want to give a hypothesis which has a negative or a positive answer, or it could be a non-directional one. And of course, it could be a null hypothesis or research hypothesis. Research hypothesis, also referred to as the scientific hypothesis, are statements of expected relations between variables, whereas a null hypothesis is that there is no relationship between the dependent and the independent variables. And null hypothesis is basically referred to as the statistical hypothesis. Now, some researchers have criticized the concept of hypothesis. They say that there is no positive contribution. It may bias research. It may predetermine outcome. Some qualitative researchers also claim hypothesis should result from investigation and should not be pre-proposed. Now, coming to the next part, data. So it is the lowest unit of information. We can have quantitative data. We can have qualitative data, which we can quantify using things like Likert scale. It could be an ordinal data, or it could be a signal data, like, for example, an ECG tracing. Now, let us look at the story of the 6 blind men and the elephant. The one who touched the tail thought it's a rope. The one who touched the trunk thought it's a wall, and so on and so forth. Now, we might have a lot of data, but if we have not formed a proper database and analyzed them properly, then we would be left by just like these 6 blind men. So planning the data collection, we have to look at the objectives and the scope with respect to the research question and the hypothesis. We have to look at the sources of information, the quantitative expression, techniques of data collection, and the unit of collection. Now, just to give a pictorial representation. So basically, the data requirements, the information source, and the budget, they all determine, we have to, with the help of these, we have to determine the sources of data, then bring up a data collection design, and finally go ahead with the data acquisition plan. So if we have to look at the flow of thought process or flow of work process, so first and foremost, with the help of the research question and the hypothesis, we have to identify the types of data, the types of measurements and variables that are required, and the various instruments, skills, and methods that we may be using, of course, after ethical committee clearance. Then we can go in for a pilot testing, and with the help of the results of the pilot testing, we can either go back to the instruments and the methods, or if we are satisfied with the results of the pilot testing, then we can go ahead with the data collection forms and the operational procedures, and subsequently implementation of the same. So the data collection sources could be internal sources, external sources. External sources could be primary data and secondary data. Primary data is the first-hand data, the merit being it has a higher degree of accuracy, but it is time-consuming and costlier. We can collect data, primary data using direct personal investigation or interviewing, indirect oral investigation with the help of case studies, through measurements, experimentation, lab results, or investigations through observation. Secondary data is something which has already been collected by others it is available through journals, periodicals, publications, official records, etc. Well, it is secondary data is indeed a quicker way of collecting the data and cheaper, but then it has poorer accuracy, obviously. So the collecting the secondary data, you can go for the published secondary data, or you can go for unpublished data. From our point of view, when we are doing health research, the primary, secondary sources could be birth and death records. It could be medical records at our hospitals, the databases, and so on. Then comes the concept of metadata. It's the data about the data. That is the method of collection, the relationship of data to the events in the research protocol, etc. For example, if we have to look at intraocular pressure, when we are mentioning the intraocular pressure, we tend to mention the time of measurement and when the last anti-glaucoma medication was applied. So this is basically an example of temporal metadata. So we need to choose when to measure, qualitative. Then coming to the primary research methods and techniques. For primary research, for quantitative data, we can fall back on surveys, experiments, mechanical observation, and simulation. For observation, could be a participant observation where the observer himself or herself is a part of the group that is observing. It could be a non-participant observation. It could be an uncontrolled observation in a natural setting or a controlled observation in a pre-arranged setting. The second method is that of the interview. So it could be a structured or unstructured interview, focused interview with the help of focus group. It could be a clinical interview or a non-directive interview wherein we encourage the respondent to talk about the given topic with minimal direct questioning. Then we come to the popular questionnaire method. A questionnaire consists of a number of questions printed or typed in infinite order on a form or set of forms. So it could be a multiple choice or closed questions, which are better. Open-ended questions are designed to permit a free response from the respondent. Gives the respondent considerable latitude in phrasing a reply. Effective questionnaire should be short, simple, have a logical sequences, best provision for indications of uncertainty like no preference, etc. should be there. And finally, we come to the method of collecting primary data through schedules. So basically, schedules is essentially collecting data just like questionnaires, but then here an enumerator is involved who is specially appointed to fill the schedules in. So definitely it is more expensive than simple questionnaires, but then it elicits a lesser number of non-responses. Finally, getting your data ready. So once we have collected all the data, now we will have to put them together using a unique identifier. Better to assign a unique identifier, organize and keep all the forms which are the back source of all your data, like the questionnaires, the interviews and testimonials. Check for completeness and accuracy of the questionnaires and remove those that are incomplete or do not make sense. So nowadays we generally going for computerized recording of data, which is basically the data availability and the calculations are much more faster there, but then the hardware and software backup, cloud support, etc. would be required. Commonly used platforms nowadays where for storing data could be Excel spreadsheets. For database management, we most often end up using software like Microsoft Access, quantitative analysis softwares like SPSS, and for qualitative analysis, we could use software like EpiInfo, InVivo, etc. Like when I was collecting data for my PhD, I used these simple spreadsheets with all the variables and the unique identifier numbers. I would also store them in SPSS, which offers both a data view and a variable view. And of course, with all these data stored, the next part is analyzing the data, which would be taken up by Dr. Morekar. And I thank you for your kind attention. So now that we have actually done the data collection and the database building, the next obvious step would be to look at the appropriate statistical tools and techniques for analyzing this data. We have with us Dr. Sunil Morekar, who is a consultant at the Global Hospital. He is a committee member of the Eye Health Committee of ICO, the Education Committee member of Council of Science Editors of the USA. He's an ex-director, Web Committee, International Association of Medical Science Educators. He's an ex-associate editor of the IJO. He's an author of International Diabetic Eye Care Guidelines, a member of the Ethics Exert database, and a WHO reviewer for ICD-11 coding of diseases. He has many publications to his name, and it is my honor and pleasure to invite Dr. Sunil Morekar for the next talk. Sir, Dr. Morekar, sir, are you muted?
Yeah, can you hear me now?
Yeah, perfect, sir. Please go on.
So thank you, Dr. Subhrangshu and Dr. Maurya for inviting me, and thank you AIS and all the esteemed members here. who are actually listening to this. So when we're talking about tips and tricks of research publication, visualization is all that matters. And this is what I have tried to say here. So you are saying this is 50% yes and 50% no. The way you put your data, that is what will create an impact. So most of the times you may actually be trying to say something else and something else gets conveyed. So you have to use the appropriate statistics tools and techniques and then submit it. So I'm combining a few things Dr. Barun Nayak has given to me because he won't be here. The slide's not moving. Yeah. So we all know what happened with HCQ. And this is a classic example because we had certain people coming and telling us there's an 80% dip in infection risk with HCQ. Then WHO recommended it, then WHO recalled it. Then they said the clinical trials for HCQ will come back again. So what was happening? HCQ in which population, where, what was being done? So there are many ifs and buts, and we were looking at study design, the forest plots, the Cochrane, and finally we came to what is called as a dynamic control trial. So we'll come to the different parts of it. But what actually happened is, just because a lot of research was being done and a lot of things were being said, and the statistics was not rightly being used, there was data visualization which misled the public into doing a lot of things which are wrong. Sometimes we think that somebody is lying with statistics, but they are actually not lying with statistics. They use the inappropriate statistics. I will give examples where I have used inappropriate statistics in the past. And there's nothing wrong in accepting that we did something wrong in the past and we change it. WHO has done it. All of us have done it. We said HCQ, then we stopped it. So my disclosures coming to this is financially nil, but these slides, most of these slides are from Dr. Nitya Gupte and Dr. Tanu Singhal. I'm also with the Cochrane Collaboration since 2006, lecture for the COPE, and I do technological review. I'm associated with WAME, COPE. These are the science bodies, editorial bodies. And I am in various committee roles, and some of these are paid, but I do not. So there are some payments made, but I do not receive any payment out of this. So that's my financial disclosure. The objectives of this presentation, at the end of the presentation, participants may be able to, if I were to give up OSCE, if there are students sitting around, I enumerate the different types of data, identify tests appropriate for the type of data, calculate sample size, identify the graph, what is represented, inferences, and Bradford Hill criteria, enumerate which test has got a good ROC. So these are some things. So let's begin. So I am here, you are here. There are times when I sit back and say I'm still here. So we have to be careful about finding out the rationale. Why did we do a particular study and what was lacking in literature, which is what we wanted to add to, and what was tested. So the broad topics of research, you may want to test the effect of therapy. So that therapy could be a drug or could be a surgery. The appropriate design would be a randomized control trial. You would want to do diagnosis where you want to find out validity, whether we can trust a particular test, let's say HRT or an OCT. Now, can we really trust this in picking up something? Then you would do what is called as a cross-sectional survey. Sometimes you want to do screening, you want to pick up the pre-symptomatic cases. If you're looking for prognosis, you want to find out the effect of early pickup of a disease. Then you want to do what is called as a longitudinal. You have to follow them up for a long time. You take a cohort and you follow it, find out that I picked this up and I intervene something, and then is it getting better or is it getting worse? What is the prognosis of the disease? I may just follow it just like that to find out natural history. And the last is causation, where we will study a cohort and compare, let's say, the effect of smoking on this cohort, or let's say the effect of steroids on this cohort, or we have a case control. We have a case group of people in whom there is something and control in whom it is not there. So we decide whether, so what exactly am I trying to look for? Accordingly, my study design should change. So Dr. Chandrama has dealt with this. So I'm not going to go into the details of this. The primary study, experimental clinical trial survey, secondary, she's dealt with all of them very well. Study designs are randomized control trials. We all know about randomized control trials, so I'm not going to go into the details of this. Instead of randomized control trials, instead of randomizing, you can have parallel group comparisons. You can have parallel matched comparisons. So you find another Sunil Morikar age and male, and you find out between paired subjects. You can have within subject comparison. Before you did a lasertomy or before you did a lacunoprost and then you did a lacunoprost, you have a comparison between matching within myself. can have single blinded, you can have blinded. You can have sometimes crossover because you want to find out that I was in this group and then I cross over in that side, does the effect goes away? Then it becomes more strongly proven that it was because of a particular drug or because of something else. So you use a timolol and a B control and then take a washout period and then switch the things and you find out what is going to happen. You can have a placebo control, you don't give anything which is going to cause any problems, an inactive looking drug or a sham. Sometimes a sham operation can also be done. And then you find out where it is moving in what direction. Some things may have two tails. My blood sugar can increase or it can decrease. So the tails of a test will be two tails when the thing variable can increase or decrease. But my height is not going to decrease. It will only increase. So then I will get only one direction change, and that is called as a single tail. You can have a factorial design which permits investigation of effects both separatively and combined of more than one independent variable. So you will have a factorial design, you will have effect of placebo, you have timolol alone, latanoprost alone, timolol plus latanoprost. So you can have multiple variables. You can have cohort studies, like I said, you study a group of people selected on the basis of difference to their exposure, let's say tobacco or smoke, and case control. So we spoke about all of this. Cross-sectional studies also, representative of a sample is interviewed, examined to find out of this thing. Case reports and case series. These case series are finally, case reports and case series are the last, but do not forget that phacomelia and thalidomide, terfenadine, itraconazole were case reports that change medicine. For that matter, Avastin is a case report which changed medicine. There were 1,849 case reports before we were forced to do a randomized control trial to say that both the drugs, Avastin and things, need to be investigated vis-a-vis each other. Qualitative research is something that I'm not going to touch into. So we want to find out whether the study is designed. So I have already said this, so we'll slightly go into, this is where we used to do the handout, but I'll slightly go into, I'm going to rush through this. So if you're trying to find out burden of illness, then you're going to do a cross-sectional study or a longitudinal study. What are the number of cases of corona here? What are the number of cases of retinal vein occlusion in corona? So you're going to look at the cross-sectional people of corona patients. So then you'll find out retinal changes in corona. You will do a longitudinal study. We'll follow them over 5 months and then find out if they get mucormycosis. So you'll have to follow them. You can't find them at one cross-section. Want to find out causation, whether this causes that or that causes this, there's a steroid causing it. Then you'll have to do a case control study, or you'll have to find a cohort in which the factor is there, the steroid is there, versus another cohort in which the steroid is not there. You will have to find out occupational risks. People are going into the corona wards and what is happening. You'll have to do ecological studies, whether you're getting the corona while going to the hospital or in the ICU or even in your OPDs. The treatment efficacy, RCT, diagnostic test, paired comparative study, and cost effectiveness, RCT. So again, I'll just put these as OCTs, as OSCEs sometimes. Study 2 surgical procedures, what would be randomized control trial. Evaluate a diagnostic test, what it would be a cross-sectional study. Prognosis and outcome, a longitudinal. You want to prognosis. Causation is a case control or case report or cohort. So we need a null hypothesis to find out that I think both of them look the same. So there is no difference. And the alternate hypothesis is no, there is a difference, so something caused something. So we need something because things look so similar otherwise, unless you look at them in minute details. So each of these things, so like if you were to look at the minute detail, I would look at the eye, I would look at, so is this different? I would look at the eye, that variable there. I will look at this variable there. I will look at the length, the width of this. I'll look at this. I'll find out if there's a gap here. I'll find out if there's a gap there. So are they different? So I will look at different variables. So what will the variables be? The variables can be discrete variable, numerical or categorical. Numerical where you use numbers, quantitative. Categorical is where you are qualitative. Why this is important? Because your test that you use statistical will depend on whether it is a number or whether it is a quality. So you have discrete numbers, discrete quantitative tests, which are integers. So progression free, after I did a chemotherapy, how many years was it progression free? Versus a continuous variable where it can take any value from height will be 170 centimeters, 72, 73, 73.4. It will be continuous, or mass or a tumor volume. The qualitative will be ordinal, which is ordered like a disease stage, grade 1, grade 2, grade 3. It goes in stages or grades. So there is an order to it. Nominal when this is not ordered, blood type or gender, these are not ordered. You have discrete values and you have continuous data. So I'm not going to go into this. Now you look at how the data is presented in your main population which you're studying, and then you're going to apply something to it. If your main population itself has a difference between the two groups, you're not going to be able to find out. So you want to find out if there is a parametric data which follows the bell curve. So it is distributed in a bell curve manner. This is something that is there, or it is a non-parametric where some things are outliers which are beyond this. So which data is normally distributed, A or B? All right. So that is A was normally distributed. Which test should be used for group A and which test should be used for group B? So you put that data in this visualization and then realize what test you want to put. So I'll come to normal distribution where mean, mode, median, all are equal and lie at the peak of the curve. 68% of the area under the curve is within one standard deviation, and normal distribution can entirely be defined in terms of mean and standard deviation in the data set. Versus distortion, these are skews, where this is a negative skews which is turning towards this side, or this is a positive skew which is turning towards this side. So most of the values are on this side of the peak. Then the mean, mode, and median are no longer equal, right? You can have a very tall curve which is called as a positive kurtosis. So it is probably normally distributed, but it is pointy, so it is called leptokurtosis. When the small number of big deviations from the mean are recorded, so it is like most of them are here, but very small this thing, and then these are very far. Or you can have a negative kurtosis where a flatter distribution is there. Now, based on these, you will like to say, what test will you do? So parametric test, or what is called as normally distributed, continuous data is normally distributed. So parametric tests are used there. Non-parametric tests are used where continuous data is not distributed. So it is continuous data, or it is a categorical or ordinal data. So you'll use non-parametric for categorical or ordinal data. For continuous data, you will use parametric tests. Comparison of two sample means, we use a student's test. The t-value is looked up, you look at the difference between the means and the standard error. So this is two tests, so this is normal. Paired t, you have two means, you have got one group and another group and they have a mean, and you find the t-test and find it paired. All right. When there are multiple data points you have, so I have done a cataract surgery and I'm looking at endothelial cell count. I'm looking at on day 0 and 5th day, there are 2 points. So you'll use a paired t because there is a pairing. You are looking at that one particular issue. But when you're looking at day 1, day 2, day 3, day 9, day 15, day 45, so you are looking at the variation. So you cannot use paired t for day 1 and day 5, paired t for day 2 and day 10, paired t for day 1 and day 40. You can't do that. You have to do what is called as an analysis of variance. You will find some of my topics, my papers which have been written where I have used paired t, where I should have used analysis of variance ANOVA. So there is a variation. So whatever we write goes against our name for the rest of our life, and somebody can find out what was done. So if there are 2 samples, paired t. This is used for more than 3 samples. Now, non-parametric tests, when the data is not proper parametric or normally distributed, normally meaning parametrically distributed with the Bell's curve, all right, you are testing proportions, this upon this, you use the Pearson's test or the Fisher's exact test. If you're using ordinal values, which are ordered, grade 1, 2, 3, 4, then you use the Mann-Whitney test or the Kruskal-Wallis test. If testing ordinal paired values, this versus this, you will use the sign test or the Wilkinson's rank sum test. Now, at the end of it all, you will look at, is the p-value significant? Now, for categorical, ordinal, or non-normal distributed, you use a non-parametric test, right? So you may check both parametric, but if you have a data point which is more than 100, sometimes you can consider that as parametric. So these are chi-square test or Pearson's test. This is something that you can put as a 2:2 table with nominal data. Whether it is getting better or worse, it is dead or alive, that is a kind of data. You non-parametric test, you will have Wilkinson sign rank or a Mann-Whitney test. So you remember this test, this is what you need to remember. I'll give you the chart at it, you can take a picture of it. You don't need to worry about why we are using which test where, but at the end of the day, your paper should have the right test for what you have done. So you are assessing the difference between 2 groups, a 2 sample t-test, if the data is parametric. If you're assessing the difference between two groups and the data is non-parametric, you take a picture of this and keep. You use a Wilkinson's or the Mann-Whitney. You can go to that test in your statistical software and apply that test. If you're assessing the difference between more than two groups, if there are two groups, you use two sample test or Mann-Whitney, Kendall's, and Wilkinson. If there are more than two groups, you use ANOVA. Like I said, more than two groups, you use ANOVA. If it is non-parametric, you use Kruskal-Wallis. If measuring the strength of association, which is something is causing something else or not, you use correlation coefficient. If it is non-parametric, it is not following the Bell's curve, then you use the Kendall tau and the Spearman. If you are assessing the difference between paired observation, you do the paired test. So पहले क्या था बाद में क्या था Latelopros के पहले उसके बाद क्या. So then you are using a paired test. If it is non-parametric, you will use a Wilkinson sign test and a sign test. Now, this is just a repetition to just hammer the point in. So we want to look at which test where that question has to be asked. If there's a difference between group, is it unpaired groups or is it paired groups? If a difference between time survival, there's a difference between groups which are paired before and after time series, crossover, these kind of things, or association between is something causing an association with something else, and an agreement between assessments. Now, which test again? I'm putting that in a graph form. You can take a picture of this again. Numerical data, numbers are there. If they are parametric, two groups, unpaired test, more than two groups, ANOVA. If otherwise, two groups, Mann-Whitney, Kruskal-Wallis. Categorical data, chi-square, Fisher's test, more than two groups, chi-square. So once you have answered what is the data, is it parametric, is the data paired or not paired, it is over multiple times or not, is the test applied appropriate, then you understood whether you applied the statistical data properly, right? So in a randomized control trial, two groups of patients were treated with two different groups. The mean ages were for 65 and 75 years respectively. What more do you need to assess this? The p-value. The p-value in the mean ages before itself is different. So there is a bias which has been introduced because of the age. Obviously, the older people are going to do bad and the younger people may do good, or the other way around. But if my basic descriptive data of the population, the two paired populations on which I was using or not using the drug is bad, I need to find the p-value, find out that if it is not right, and you find it, p-value is not given, but you calculate it and find it to be 0.02 for the mean in the two ages. What is the interpretation? That is improper randomization with significant baseline differences. The baseline is also already wrong. So you will have the baseline of both written must be given, and they should be compared by appropriate statistical tests. There should be no difference between the groups if randomization is proper. Then you apply the RCT or the intervention, and you find the RCT compared mean IOP following anti in two groups by the Friedman test. Is this correct? Incorrect? Suspicious? This is suspicious because you're suddenly using a test which we don't usually talk about, right? So again, one more time, compare means from independent sample, student T, non-parametric Mann-Whitney and Wilkinson. If it is paired samples, paired T. If it is paired, paired T. Independent samples, student T. More than two, ANOVA or Kruskal-Wallis if it is non-parametric. Comparing proportions, chi-square, Fisher's. McNemar's if it is compared proportions from paired samples. And comparing two variables which are continuous, Pearson's or Spearman's. Pearson's is used for parametric data, Spearman. So sometimes you use Pearson, sometimes you use Spearman, and I will use Spearman's in a normal this thing. So I have a study in which I have used parametric data, but I have used the Spearman's coefficient. I will get a different interpretation altogether. Or if I have a non-parametric data and I use Pearson, so you look at the data and you look at whether this is parametric data or non-parametric data, and the person has applied the right test there. So you say coefficient is significant, but you find out which coefficients, Pearson's or Spearman's, and based on the parametric or non-parametric. So two drugs found no overall difference, but A was better than this thing in the Chinese age group between 41 and 50. This is what people do. This is what is called as a subgroup analysis. I want to find a difference. So I'll keep on breaking that group and keep on breaking that group into smaller segments till I find a difference. The sensitivity for a test is reported 75%. So we'll come to sensitivity and specificity and CIs. So I'm not going to talk about this here right now. I'll skip this. So the other thing which is important that you have to look at whether the sample size has been calculated. So sample size was calculated in this manner. If the sample size is not calculated, I will not like that particular paper at all. Then the sample size has to depend on whether there's a type 1 error or a type 2 error, one-sided, two-sided, what is the variability? There is an inherent variability in the population. My sample size has to be bigger.
Sir, I request you
one
to
side or two
kindly
side.
conclude
Then you go
and clear
to sensitivity, specificity. Sorry, are we running out of time? I'll just stop here.
this. I request you to kindly conclude.
Yeah.
Yeah,
So we look at samples. When you look at test, whether it is helping me diagnose something, we look at specificity and sensitivity. So we find out the patients with disease, without disease, the test results are somewhere here, and you find those out. So this is how you find out sensitivity, specificity, and the ROC. I'm going to run through this. And that is a good test, and this one is a poor test because the area under the curve is like this. If there is a less area under the curve, it's not a good test. This is the worst test. And then you find out correlations, like I said that, and you can find these perfect correlations and then regressions. So this is something, and then at the end of it, you find a survival analysis and Kaplan-Meier estimator for the survival analysis. So you find out this is the survival analysis and this is what will you find out? How will you do that? If it is non-parametric, 2 groups, Mantel Hansel, log 1, and if it is more than 2 groups, log rank and Mantel Cox. So that's it. And at the end of it, there are biases. There is a selection bias, attrition bias, measurement bias. There are multiple biases that are there. You got to look at whether your data has some bias and something is showing a bias, and were efforts made to minimize the bias. The survey is going to find out awareness about glaucoma in a patient who are exiting from an eye hospital. Obviously, what is the problem here is a selection. They are already coming out from a hospital where they are aware of it. So you want to find out awareness of that. Then postal survey on sexual practices of adolescent girls only. So this is a selection bias. Only 20% responded. In a case you find out controllers are admitted to hospital's trauma ward. Again, what is the problem? Selection bias. So there are multiple biases that can be there, and incorrect randomizations. So you find out those biases, and at the end of it all, last slide here, you're looking at Bradford Criteria, where you're looking at 10 criteria. What is the strength of the effect? What is the consistency? Can it be reproducible? Can it be specific? Is it temporal? One thing started after the other? Is there a biological gradient? Is there a plausible mechanism? Is it coherent? Can an experiment be done to this thing? And an analogy to other things can be found out. So if those things are there, then you will think of the association as a causal association. And finally, if you think my presentation was just average, it's quite all right because it is being me. Thank you. Thank you.
Thank you so much, sir. Thank you so much, sir, for this exhaustive presentation. And we now move on to the talk by Dr. Santosh Honavar. He'll be speaking on choosing the journal. So Dr. Honavar needs no introduction. Just to say, he's a world-renowned ocular oncologist and oculoplastic surgeon, and is currently the editor of the IGO and the Indian Journal of Ophthalmology Case Reports. He's a director of medical services at Center for Sight. He's a former head of the Department of Plastic Surgery and Ocular Oncology at LV Prasad Eye Institute. The CSIR awarded him the Shanti Swarup Bhatnagar Prize for Science and Technology, one of the highest Indian science awards for his contribution to medical science in 2009. He is counted among the top 2% of the world researchers, and he's one of the few Indian ophthalmologists to receive the Lifetime Achievement Award by the American Academy of Ophthalmology and the Honorary Fellowship of the Royal College of Ophthalmologists, London, UK. Over to you, sir, for your presentation.
Thank you, Subhrangshu. I after all these wonderful talks, I'm just talking about a very small aspect, how to find a good journal for publication. I think Sunil deserved a lot of more time because his talk was excellent, and I think he had to rush. Anyway, so I'm going to talk about how to try to find a journal that is appropriate for your publication, because it's a jungle.
IGO, no? Santosh, only IGO.
All right, it's a jungle out there because there are too many journals that are there, and you really don't know how to find a right match. So it's all about finding a right match. So what is your best target journal? So your best target journal should be one which has some professional repute. You're aware of it. It should be an index journal. It should be published by a professional society. For example, ophthalmology is an official journal of American Academy of Ophthalmology, whereas IGO is an official journal of All India Ophthalmological Society. So when you know that these are journals published by professional societies, there is some amount of reputation that comes attached to it. Does it have a good impact factor? This is, of course, one of the criteria. Is it regularly published, or the issues too delayed? Is the review time compact? And what about time to decision? Reasonable publication time. So after it is accepted, is it published within say 2 or 3 months time, or is it stretched beyond a year? And does it cater to your target audience? So that's always important, because if you publish about epidemiology of a particular disease in African Journal of Ophthalmology, then obviously you're totally out of target. People will have to go to a search database to find your article. Then that is a journal, and you have to match it with the type of article that is yours. Is it just an image? So there are only few journals which publish images and photo essays. If it's a case report, obviously it has to go to a journal which publishes predominantly case reports. There are special journals for case reports. Is it a surgical technique? Then your choice of journals is narrow. If it's clinical research, basic translational research, obviously they're diametrically opposite, so you have to choose an appropriate journal. Review articles are published by fewer journals such as Survey of Ophthalmology. If it's a meta-analysis, then you have to target a journal appropriately. Then is your topic of general ophthalmology interest, or is it of subspecialty interest? For example, if it's on cataract or glaucoma, then general ophthalmologists may be interested. But if you have worked on a very complex neuro-ophthalmological problem, then it must have to go to a subspecialty journal. Then is your research a breakthrough? Then you have to really target at a very good journal, because you know that your research is of great importance. But if it's just an incremental study or a replication of data that is already there in your own set of patients, then, well, of course, you can choose your journal. The main factors that will help you choose a journal are scope of the journal, reputation, and turnaround time. Now let's see what is this. What do I mean by scope? Does it fit the focus area of the manuscript? Again, giving example of ophthalmology and ophthalmology retina. If your manuscript is very highly specialized in, say, surgical retina, then you have to probably submit it to ophthalmology retina, which is just a sister or a co-publication of ophthalmology. Whereas if it's a general ophthalmology article, then it will find place in ophthalmology if it's very good. Does it regularly publish and in good numbers? The category of manuscript that you're aiming at. So for example, if a journal publishes just 1 or 2 case reports, then your chance of acceptance is limited. But if a journal publishes say 8 to 10 case reports regularly every month, then you're looking at a good scope of acceptance. Does it serve your target audience? That means the geography of the journal publication. So you have to know your audience. What kind of audience are you looking at? Are you looking at members of All India Ophthalmological Society, or is the world your stage? Coming to the reputation of a journal. Years in publication is one indicator, but doesn't mean that journals which are 60, 70, 80-year-olds are still doing well. One ideal way of looking at it is it indexed or not. Indexation is a good indicator, because when it is indexed, a lot of factors are considered, and indexation is a process in which the journal's quality is regularly assessed. Is it from a regular professional publisher, reputed professional publisher? Is it an official publication of a reputed professional society? Does it have a good impact factor or a site score or a H index? And are your peers, the group that you're targeting, are aware of it or aware of this journal? Are they regularly accessing it? You have to be aware of the predators. Now there are two sets of databases which you can go to know what is a predatory journal. One of which is a criteria. This is World Association of Medical Editors criteria to identify a predator journal. Basically, a predator journal is from an unknown publisher with a set of unknown editors. For example, if you are in ophthalmology publication business, who are the reputed members of the editorial board in your own geographic area. And if it is very obscure kind of names or obscure publisher, then that raises suspicion. If a journal solicits publication, repeatedly emails you or contacts you by various means of communication and asks for publication, charges a hefty publication fee, has no or minimal peer review, or a peer review is so minimal that they simply accept it without asking for improvements or corrections, and the publication speed is really lightning. Within a week, you find the article online already. The journal is not indexed, and it is not in the directory of open access journals. And these are the two databases that will give you all the predatory journals. So you can actually look at it and then see if the journal that you're targeting finds place in one of these databases, which means that it's a predatory journal. There are other ways of identifying whether it's a predatory journal or not, but basically the criteria, 10 criteria that I told you are the ones with which you identify a predatory journal. Predatory journals are typically open access journals. Not all open access journals are predatory. In fact, open access is the current standard of dissemination of knowledge. So open access is good, but open access, which is profit driven and based on fraud and deceptive practices, is a predatory journal. So that you have to be aware of. Now the turnaround time. What are the classic turnaround times that you have in scientific journals? 6 weeks to 3 months is fine. 6 weeks is the time that it takes for a first decision, and 3 months is for the final decision. That is the standard of journal practices most of the journals follow. Initial, if you break it down, initial technical check is done in 1 week, peer review in 6 to 8 weeks, re-review in 3 to 4 weeks if it's re-reviewed for a next decision. Acceptance to proof is 4 to 6 weeks, and acceptance to publication is another 3 to 4 months. Or if it's delayed beyond 3 months, then some journals offer an ahead of print early online version. So that is also acceptable. So these what I have listed here are the standard timelines for publication. So this is the final checklist I'm going to give you. Does the manuscript fit the scope of the journal? Does your manuscript fit the scope of the journal? Is the readership your intended target? So basically you have to look at whether it satisfies your regional and country criteria. Are you looking at comprehensive ophthalmologists or subspecialists, basic scientists or clinicians? Is the journal popular among your peer group who you're targeting? Is the journal optimally visible? This is very important because you have to be able to, or your targeted readership has to look at the journal and pull it up using digital databases such as PubMed and Google Scholar. Is the journal accessible, or is there a hefty accessibility fee? That means that is it a paid journal? Each reprint costs about $30, $60, $100, then people may not be able to access it. Is the full text on PubMed or is it open access? So open access journals are favored currently as well because there is no access fee to it. And how about the acceptance rate of the journal? Is it a measly less than 10%, which means that your manuscript may not stand a very good chance? Or is it about 20 to 30%, which is healthy? So if you have 20 to 30% healthy acceptance rate, then you may want to prefer the journal. Further, does publication in a particular journal add value to your CV? In front, in terms of good editorial board, affiliate society, etc. Is the turnaround time optimal, or would your work get aged waiting for publication? If the relevance of your work is lost, then that is not a good decision. Submission to first decision and decision to publication are the two parameters that are usually considered when you talk about turnaround time. Is there a publication fee? This is very important. And can you afford that fee? Well, some of the reputed journals, to maintain themselves in a very healthy shape, financial shape, and kind of have a longer life, otherwise journals can fold up very easily because of financial issues. They do charge a publication fee, which is very healthy. It's called article processing charge or color image processing charge. If it's reasonable and if it's a reputed journal, well, you can go ahead if you can afford it. Suppose you cannot afford it, then you can possibly ask them to publish with black and white images, or ask them to restrict open access. That means some journals charge the authors an additional fee to have it open access. So those are the mechanisms that you can play around with, but it has to be affordable and it should not be a predatory journal. So finally, you have to fit your manuscript to a target journal, and that was the idea of this talk. Thank you so much.
Thank you so much, sir, for this crisp presentation. It's an eye-opener of sorts for us. We next move over to Professor S. Natarajan. Sir is currently the Chairman and Managing Director of Aditya Jyot Eye Hospital. He is the past president of AIOS, and he received the prestigious Padma Shri Award in 2013. Sir postgraduated from the University of Madras, did his fellowship in retina and vitreous surgery at Shankar Nethralaya. He is a fellow of the Royal College of Physicians and Surgeons, Glasgow, and a fellow of European Latino American Society of Ophthalmology. Sir has numerous publications and has received numerous national and international awards. It's my honor and pleasure to invite Sir for the next talk.
Thank you. Thank you very much for having me. And this is my favorite session. And I have my favorite friend here, Santosh. Thank you, Santosh, for a wonderful talk and wonderful work. And I think we all should congratulate the IJO editor for having the highest impact factor in the past decade, I think, and plus the history of All India Ophthalmic Society since 1930. Heartiest congratulations, Santosh.
Thank you.
So, thank you, Santosh. So, can you see the slides? Yeah?
Yeah.
Yeah, okay. Tips and tricks of research publications, ethical consideration, the financial disclosure and plagiarism and publishing research. So the ethical consideration, ethics are norms of conduct that distinguish between acceptable and unacceptable behavior. Ethics are the principles and guidelines that helps us to uphold things. So research ethics involves the application of fundamental ethical principles to a variety of topics involving scientific research. Research ethics educates and monitors a scientist conducting a research to ensure a high ethical standards. So when I became editor in 2011, I learned this, and this was one of the topic which I was making the research methodology workshop. So when you have importance of research ethics, the same thing can be applied for clinical practice, clinical research, and basic science, or anything, I mean, even to life. Respect and cause no harm to the participants. As a sign of respect for other researchers and cause no harm to the participant. It is a professional requirement. It is a requirement to obtain funding. Failing to conduct research ethically result in researcher being dismissed or rejected by the research community. The basic principles of research ethics: honesty, objectivity, the respect for intellectual property, objectivity, confidentiality, integrity, respect for colleagues, carefulness, non-discrimination, openness, social responsibility. Important areas are again authorship, plagiarism, peer review, research with animals, research with the human subject, and research misconduct. The authorship, I think this is the most important for anybody before starting writing anything, whether it's for a peer-reviewed journal or for any of the magazine or even the any journals. Research evolves from collaboration and assistance between experts and colleagues. Authorship is the process of deciding about on who names a research paper belongs. Authorship is reserved for a person who receives primary credit and hold primary responsibility for a published work. It decides which colleagues should be listed as authors or co-authors. And each author should have participated sufficiently in the work to take responsibility for the content. This participation must include conception or design, or analysis and interpretation of data, writing the research paper itself, or all of the above. An acquisition of funding, collection of data, or general supervision of the research group alone does not justify authorship. Order of author names. According to the COPE guidelines, the sequence of authors should be determined by the relative overall contributions to the manuscript. The order of authorship on byline should be a joint decision of the co-authors. An author should be prepared to explain the order in which authors are listed. The first author should be that person who contributed most to the work, including writing of the manuscript, should have conceptualized the design, defined precise method, participated in a major way in analysis and interpretation of results, and written the paper. The lead author, a person who is responsible for ensuring that all other authors review and approve the final version. Co-author should have made significant contribution to the planning and execution of the research, the methods and procedures, the collection and analysis of the data, etc. The group author, when submitting a manuscript, the corresponding author should clearly indicate the preferred citation and should clearly identify all individual authors as well as the group name. How to avoid problems with authorship. And this is the most important. Agree with your team that you will follow the international guidelines. COPE, Committee on Publication Ethics. Agree before starting the research. That means when a professor is calling a student or a junior research fellow or a postdoc and ask him to start a research, if he's joining a new organization, who will be an author, order of authors, and if necessary, discuss why each person should be an author, clarify the requirements. And we are doing a extensive research with Cleveland Research, Cleveland Clinic, not Cleveland, sorry, Cleveland Case Western University, where we actually work for so long and we are very clear who will be co-authors, who will be corresponding author, who will be a lead author, and who is the first author and who is the last author, because even the last author is an important person, maybe the head of the department. But again, if you see in the previous slide, it has to be contribute, not just because it's the head of the department or I'm head of the hospital. And I hate if somebody includes my name and I make sure I withdraw the paper. So the people are afraid to include my name. So you should not be a co-author just for the sake of it, whether you're a head of the department or a head of the institution. And this is for the head of the institute. But as a student, I think you have to find a way how to start working, and you have to probably even choose a teacher who will follow all this. And reviewers can also engage in unethical behavior, bias, conflict of interest, misappropriation of privileged information. And reviewers are obligated to maintain confidentiality, inform the editor if circumstances preclude an unbiased review or could represent even a perceived conflict, provide fair and collegial assessment. Sometimes you may have something as a research idea and somebody is sending. I think you should be really fair with yourself and tell the editor, I will not edit because I have already my idea and I don't want to be a reviewer for this article. And that's a ethical part of the reviewer. So one is who writes it, who's the co-author, who's the lead author, plus the main author and also the reviewer. So financial disclosure, the basics. Goal, reduce potential for bias in clinical studies and enhance human subject protection. Implemented by FDA rules at 21 CFR Part 54, February 298, published in FR effective 1 year later. And the FDA guidance, financial disclosure by clinical investigators, it's dated March 20, 2001. Requirement for any manuscript submitted, disclose data on the financial interest of clinical investigators of covered clinical studies or certify there are no disclosable interests. And plagiarism in publishing research, it's exactly, see, the boy behind is copying. And this is where you should know that just copying is a plagiarism. And the use of word plagiarism in the English language dates back to 1600s. It is derived from the Latin word plagiare, which means to kidnap, the deliberate or reckless use of someone else's thoughts, words, or ideas as one's own without clear attribution of their source. There are a lot of softwares to find out, but still, I'm thankful to many reviewers. I remember withdrawing one published AIOC article where it's about a 15-page article, a basic science article, our own Indian author. He had published in some other basic science or a material science journal, and then he had the same paragraph in his, and then without realizing, he thought probably somebody will not find out. The plagiarism software missed it, but somebody had reviewed and somebody read somewhere and they asked for the article and got back, and we finally withdrew the article. I know it's a black mark for the journal, but it also shows that the editor is following the rules of COPE. And what is plagiarism? Deliberate. There's a difference between deliberate plagiarism and accidental plagiarism. Do you know in law, you can have also a deliberate murder and accidental murder. But do you think you will be not punished for accidental murder? Murder is a murder. So unless you prove some other way that the murder has happened, I think it's very difficult. If you have accepted you've done a murder, you have to undergo punishment. Same thing here. Deliberate plagiarism or accidental plagiarism. Deliberate is rewriting from books or articles, copying and pasting from web pages and online sources to create a patchwork writing, buying, downloading, or borrowing a paper. And that is deliberate. So I think this is what I said. You learn honesty, you learn how to be good in yourself when you're an editor of the journal. And that's particularly an Indian journal, which is there for more than almost reaching 70 years now. So it's great that forefather, like it started by Dr. S.N. Cooper in Mumbai. And I'm glad that AIOC was started in Mumbai and AIOC was started in Chennai from where I belong to. So the deliberate plagiarism is sometimes you say, I don't know, but I want every student, everyone who's attending should know that. And in case you have accidental plagiarism, this happened to our Bharat Ratna CNR Rao. He said, my student has done it and accidental plagiarism happened. And he also said, I don't know that he copied a paragraph from his own article where he was also co-author in a new article. And then the journal, which was a high impact journal where CNR Rao published it, said they will not allow to withdraw the paper. They will say this paper has been plagiarized, and he was punished by publishing that he made a plagiarism, even and mentioning that his fellow did it. But the bad name is to the Dr. CNR Rao. He's a Bharat Ratna, and what an amount of publication. But accidental plagiarism is also not allowed. You will be punished. Not knowing when and how to cite, not knowing how to paraphrase or summarize, not knowing what common knowledge is, and recycling an old paper. So best is the type of plagiarism. There are several plagiarism. Best is you should know what is plagiarism and you should know how not to do it. It's like having a complication of cataract surgery, and you cannot say, I did surgery, but I don't know that this complication will happen. No, you should know everything. Then only do the surgery. Same thing here. Plagiarism of ideas, plagiarism of text, self-plagiarism, and plagiarism of ideas. An author does not copy any words and phrases from the original article. If he simply uses the same idea, thought, or invention and presents as own without proper acknowledgement. Mosaic plagiarism, borrowing the ideas and opinions from an original source and a few verbatim words or phrases without crediting the original author. In this case, the plagiarist intertwines his or her own ideas and opinions with those of the original author. And
Dr. Natarajan, may I request you kindly conclude?
Okay. In scientific writing, plagiarism is regarded as a serious breach of ethics. Authors have a responsibility to ensure that they make due acknowledgement every time they use ideas or words of others. Editors of scientific journals also have a responsibility to discourage plagiarism. So they are a copyright infringement, plagiarism, and avoiding plagiarism is not always easy, and it is inevitable that so common tips for avoiding plagiarism and acknowledgement. And then you can use a medical writer should avoid writing multiple separate articles if you can present at a large complex study. And confess yourself, last but not at the least, if he feels he has unintentionally used somebody else's ideas or text without appropriate referencing, he needs to write to the editor of the journal for advice. Confession is always better than to be caught stealing. Thank you very much.
Thank you, sir. It was a pleasure listening to you. And thank you to all the other co-instructors of this session. I now conclude this session and hand over to the next chairperson. Thank you so much.
Thank you so much. Thank you so much, Dr. Senguta. Thank you so much, all the speakers. Thank you. Ladies and gentlemen, with that, we are quickly moving into the next